My name is Janet Goriev, and I am the Senior Health Education Engagement Specialist with Brain Tumour Foundation of Canada. And thank you so much for joining us for our third webinar of our 2021 webinar series. Our mission is to reach every Canadian affected by a brain tumor through the 4 pillars of our organization, which is information, support, education, and research. And this webinar series is really just one educational program that we do offer through Brain Tumour Foundation of Canada. So we really encourage you to check out our website at braintumor.ca for regular updates, or follow us on social media for regular updates on different programs and resources that we do launch. And even though our office is closed during the pandemic, unfortunately here in London, Middlesex, we're back into the red zone, unfortunately. But even though our office is closed to the public, we are open. You can call the 1-800 number, you can email us, and we will respond within an appropriate amount of time. And we have organized the webinar series a little bit differently this year. So each webinar every month that we do host one, we're going to have 2 presentations, one typically from a healthcare professional kind of giving a educational type presentation, and then a personal story of hope, which is what we have today as well. So I'm very excited. Dr. MacNeil, you can show your screen now if you want, and turn on your video, and I will do an introduction. We'll just get you organized here. I'm going to stop sharing my screen so you can do that. So you'll see the little green button on the bottom, Dr. MacNeil.
Yeah, okay. Now it says host disabled participants screen sharing.
There we go. I'm going to switch that over for you. Make co-host. Does that work now?
Yes.
Perfect.
Okay.
We love technology when it works, right?
Yes. And now I'm going to see if this works. Can you see my slide?
Not yet.
Not yet.
So you have to click the green share screen, and then you have to click on the file we want to share. There we go. Something's popping up here.
Okay.
I see it now.
Okay.
Does that work for you on your end, Dr. MacNeil?
Yes. Can you see it now as a presentation?
I can see it, but I can also see your notes panel as well.
Okay. So maybe I think I just need to pick the particular screen. Does that work?
I still see your notes.
Dr. MacNeil, I think you can just go ahead and start. There's a very, very top left. There's a button that says start the slideshow. That's perfect.
There we go. Yep.
Now you can see it?
We're good now. Great.
Okay,
Well,
great.
thank you, Dr. MacNeil. So yes, Dr. MacNeil is joining us from Halifax once again. So great that we have this technology to have you with us today. Dr. MacNeil received her MD from Dalhousie University in 1989, and in 1997 she completed her medical oncology subspecialty training at the University of Ottawa. And following completion, Dr. MacNeil completed a fellowship in clinical trials with NCIG CTG, which I believe is the Canadian Cancer Trials Group. Is that right, Dr. MacNeil?
Yes. Yep.
At Queen's University in Kingston, Ontario. And from 1998 to 2006, she was clinical instructor, Department of Medicine, University of British Columbia, Faculty of Medicine, Victoria, BC. During that time, her hospital appointment was with BC Cancer Agency, Vancouver Island Centre, Victoria, BC. I love Victoria, as a medical oncologist. And in 2006, Dr. MacNeil moved to Nova Scotia and is now assistant professor, Department of Medicine at Dalhousie University. She's a member of the Division of Medical Oncology, Department of Medicine at the Queen Elizabeth II Health Sciences Centre and the Nova Scotia Cancer Centre. Her areas of interest are neuro-oncology and thoracic malignancies, and she is also the co-chair of the Neuro-Oncology Cancer Site at the Nova Scotia Cancer Centre. That's wonderful. Dr. MacNeil's presentation is entitled Brain Tumor Treatment, Side Effects, A Holistic Approach to Management. Thank you again for joining us today, Dr. MacNeil, and I will pass it over to you, so to speak. I will mute myself for now, but if you need me, I am not far.
Okay. Well, thank you, Janik, for that kind introduction. And I want to thank the Brain Tumour Foundation of Canada for inviting me to speak. And I'd also like to thank all of you for taking the time to attend this session. And of course, the title of the talk is Brain Tumor Treatment Side Effects, a Holistic Approach. In terms of disclaimers, I have no ties to pharmaceutical companies. I am a medical oncologist, and my only other disclosure is that I have 3 Siamese cats. So I geared a lot of this talk towards patient and caregivers, but I know there's some healthcare professionals on board as well, but I think they'll also find this useful. So patients undergoing treatment for primary brain tumors, they can experience a complex array of symptoms. So in addition to the side effects of treatment, the neurologic symptoms from the tumor itself and the side effects from other supportive medications such as steroids and anti-seizure medications, many patients are going to experience cognitive difficulties, fatigue, and emotional distress. Now, these more general symptoms, they can often predate the diagnosis, and they're not necessarily related directly to where the tumor is located. They can occur secondary to treatment and adversely affect one's quality of life. So many times the symptoms are interrelated and they can always also occur at the same time. So while all of these issues are important, in the interest of time, what I've decided to do is narrow it down to 3 things. So we're going to focus on the side effects of radiation and chemotherapy in the context of treatment for glioblastoma. We're going to talk about steroid side effects and fatigue. Now, while I just want to go through the objectives here. So number 1, we're going to become familiar with some of the common side effects of radiation and chemotherapy. Number 2, we're going to understand the role of steroids in the treatment and their side effects, and understand the causes of fatigue and management strategies. Now, before we begin the main part of the talk, I just wanted to briefly review some background about the types of brain tumors and how people present to medical attention so that everyone is going to be on the same page when we go to the rest of the discussion. So primary brain tumors, what does this mean? So when we say this word, this is a tumor that develops within the brain, and it can be benign or malignant, and it doesn't come from somewhere else. So each tumor presents with certain symptoms, and they can all have their own biology, prognosis, and treatment. There are about 100 different types of brain tumors, and these are characterized in this lovely book here by the WHO. Now, despite this large number of tumors, there's going to be some that are more common than others. The Central Brain Tumor Registry of the United States, they've been collecting data that shows the number of cases of both benign and malignant tumors each year in the US. And this pie chart shows you that in blue, about 70% of tumors are benign, and the most common one being meningiomas, which can often be cured with surgery. The remaining 30% in red are considered malignant, and the most common among these is glioblastoma. Now, glioblastoma belongs to a class of tumors called gliomas, and their behavior is described in terms of grade. We don't stage these tumors like other types of cancers. So the higher the grade, the more aggressive a tumor will be. And glioblastoma is grade 4, and that's our highest grade. So the glioblastoma and the other gliomas, they make up the majority of tumors that I see and treat. In Canada, there are about 8,300 new diagnoses of primary brain tumors, which include benign and malignant tumors. But if we look at just the malignant tumors compared to other types of tumors, these represent about the 16th most common type of cancer. All right, so how do these tumors present? Well, patients often present to medical attention with seizures, headaches, neurologic symptoms, cognitive difficulties, or sometimes a combination of all of these. Imaging of the brain is done with usually a CAT scan followed by an MRI. Now we can see in the MRI in this picture here, the little bright white area that outlines where the tumor is after we've given contrast. So it appears on your right, but it's actually on the left side of the patient at the back of the brain. A neurosurgeon then becomes involved, and they'll either biopsy the lesion or remove as much as possible. The tissue is then sent off to our pathologist, and they'll look at it under the microscope, and using the criteria from the WHO, they'll tell us what type of tumor someone has. Now, while some benign tumors can be removed and cured with surgery, glioblastoma can't be completely removed, and there will always be some cells remaining, and therefore the need for further therapy. You can see in this picture here on the right that the tumor cells are depicted as small little blue cells, and they spread out along nerve fibers, and these are the ones that can't be removed. So patients are therefore then sent on to the cancer center, where we discuss the need for radiation and chemotherapy. And in Nova Scotia, we have 2 cancer centers, one in Cape Breton and one here in Halifax. So since glioblastoma is the most common primary brain tumor, malignant brain tumor in adults, and the bulk of what I see, that's what we're going to really focus our discussion on for treatment. So since the publication of this study in the New England Journal in 2005, this has been the standard of care for the treatment of glioblastoma and involves a combination of radiation and oral temozolomide chemotherapy. Prior to this, many patients would have just received radiation alone. And if you look at this diagram where the surgeons are operating, you'll notice there's a long black arrow through the middle of the picture. And this represents the passage of time, and each small black bar represents weeks. So the orange arrow shows you that radiation, which is depicted in pink here, is given as small doses for 5 days a week for 6 weeks. The second arrow on top just shows you that temozolomide chemotherapy, which is colored in blue, is taken during radiation every day for 6 weeks as well. There's about a 1 month recovery, and then temozolomide is taken on its own for about 5 days in a row every month for 6 months. Okay, so now that we have the background about brain tumors and the treatment of glioblastoma, we're going to go back to our objectives, and we're going to start with number 1, and that is becoming familiar with some of the common side effects of radiation and chemotherapy. So let's look at radiation first. So after consultation with the radiation oncologist, before even starting treatment, patients will have a mask made, and this helps keep someone in the same position on the treatment machine table each day, because you want to give the most accurate dose of radiation to the tumor while limiting the dose to the normal tissue. So you want to give the high dose to the tumor. Now, if you look at the picture on the bottom left of this slide, this kind of depicts in a cartoon fashion how radiation is given as beams of energy in small doses or fractions each day. And each beam is going to pass through normal tissue at multiple spots. And then it's focused in on the tumor like a magnifying glass. And we're trying to ensure that the tumor receives the highest dose of radiation while normal tissue is hopefully going to get much less. Now, if you look to the right of this picture, you'll see what's called the planning MRI. So when a patient is given IV contrast, as I pointed out, this leaks out of the tumor blood vessels and allows us to see where it is. So in this case, the tumor is in the right hemisphere. Now to the right of this picture, you can see how the radiation oncologist actually plans out treatment. Oh, sorry. So all of these little circles represent different areas of radiation planning and a different dose of radiation that people receive. So you can see there's an area around the tumor, but they also need to include a much larger area. So they include all those microscopic spread areas. Now, the reason I show you this slide is really to demonstrate that there can actually be a fairly large area of the brain that receives radiation. And the larger the field size, the more toxicity that people will experience, including fatigue. So let's go through some of the side effects from radiation. Now, we tend to think of these side effects as occurring during radiation, in the first few months after, and then even years later. Some of the acute side effects during treatment include swelling of the brain around the tumor, and this often requires using steroids to help control this edema. Radiation can cause hair loss, specifically over the area that's treated. The hair can regrow after radiation, but it can take a long time and it is a little bit thinner. And towards the end of the radiation, which we talked about is around 6 weeks, this is when most patients will actually start to experience fatigue. And in the first several months after radiation, there can still be problems with swelling, and steroids are needed again, and fatigue can persist. So you're starting to see a theme here of the need for steroids and also the fatigue that develops. Now, this is also the time in that first 3-month period where people are starting, but perhaps to develop memory problems. And it's also during this period that we can see a phenomenon called pseudoprogression. So this is where on imaging, the tumor might look worse, but it's actually just kind of an exaggerated response to treatment, and that'll settle down eventually. As you can see, even years after radiation, there can be late damage to tissue. Sometimes we need to use steroids then again as well. Long term, there can be worsening cognitive issues for people, and also, believe it or not, ongoing fatigue. So I think this slide demonstrates that we do need steroids quite frequently, and fatigue is a prominent symptom, and that's why we're also going to be discussing those later on. So let's move on to chemotherapy. So when we look at drug therapy in oncology, we often use a more general term called systemic therapy. So drugs can either be taken by mouth or IV, and then they're delivered to the tumor through the bloodstream. Now, within this category of systemic therapy, there are many different types of drugs. So most familiar to people and still the mainstay of treatment for many CNS tumors is chemotherapy. Temozolomide, as already mentioned, is what we'll be discussing today. There are other types of chemotherapy, and there are other classes of drugs, but these are beyond the scope of our talk today, but all very promising. Now, let's go through some of the side effects that you can get with temozolomide chemotherapy. Some of them are common, and some of them are less common, although just as equally important. So let's just go through a few. So there can be nausea related to temozolomide, but we have excellent medications that really can help control this. Now, unfortunately, this drug ondansetron, which helps with nausea, can also cause constipation, and that requires medication as well. So you can sometimes get into a little vicious circle there. We know that there can be low white blood cells, and those can put people at risk of infection. And sometimes we will use a prophylactic antibiotic to prevent certain types of pneumonia. More commonly, actually, we tend to see the platelets decrease, and these are the cells that we need to prevent bleeding. For this reason, blood work is going to be monitored quite frequently, and if the platelets go down to a very low level, people may need a platelet transfusion. And of course, we cannot escape fatigue. So chemotherapy adds to the fatigue already caused by radiation. And this is a topic, as I mentioned, we're going to cover later. There are other less common side effects. So sometimes people can have a rash, and determining the cause of a rash is not always easy. But when other drugs are ruled out, sometimes antihistamines are good at controlling itch. It's very rare to have a serious allergy that would require us stopping temozolomide. Liver toxicity also has been reported. It is rare, but it is a serious complication, and that would require us stopping the chemotherapy. This is monitored through regular blood work. Otherwise, hair loss tends to be quite rare with temozolomide, and in younger patients, we'll also discuss issues of fertility. So although we've discussed radiation and chemotherapy in the context of glioblastoma, many of the side effects are actually generalizable to the treatment of other tumors. So now, that was kind of a brief review of that. We're going to move on to our second objective, and that is to understand the role of steroids in treatment and their side effects. So the overall class of drugs are called corticosteroids, and the one that's used most commonly for patients with brain tumors since about the 1960s is called dexamethasone, or you might be more familiar with the term Decadron. So glioblastoma, as we've noted, has leaky blood vessels, and that can leak fluid into the surrounding brain tissue, leading to brain edema or swelling. Now, as a consequence, this can cause a number of symptoms, including headaches, worsening seizures, neurologic symptoms, and cognitive disturbance. And actually, if the swelling is severe, this can lead to pressure on other brain structures and coma. Dexamethasone helps control these leaky blood vessels, resulting in decreased swelling. If you look at the first picture, the T1 post-contrast MRI, this demonstrates how the leaky blood vessels within the tumor allow contrast to escape into the surrounding area, and then we can see part of the tumor. The picture next to this one, the T2 flare image, shows the surrounding edema as a white hazy area, and that's the area that the steroids are hopefully reducing to improve symptoms. Steroids, they can be thought of as an adjunctive medication, so one that is given in addition to the definitive treatment of surgery, radiation, and chemotherapy. So it does not treat glioblastoma, but rather just helps with the edema. Now, the dose needed depends on the amount of swelling, the degree of surgical debulking, and how well the tumor is controlled by treatment. Now, most patients are going to respond within hours of starting steroids or increasing their dose that they're on already and reach full effect within about 24 to 72 hours. Now, while steroids provide significant benefit, they do have the potential to cause significant adverse effects, and this is what can really impact one's quality of life. So once someone's symptoms have stabilized and the tumor has stabilized, we try to reduce the steroids. And the reason we do this is because of the significant side effects. So what are some of these? Well, this is a long list of the potential side effects, and we won't go through all of them in detail. I've kind of organized them as a large category, but we will try to go through a few of them. So I would say that the most problematic side effect is what we call proximal myopathy. And this is a significant problem leading to mobility issues and falls. Many patients have difficulty getting out of chairs or going upstairs. Steroids can also affect someone's mood and also cause insomnia. So what can someone do? Well, I know it can be difficult, but exercise can be very helpful. And if possible, it's important to try to do that early before someone has lost too much muscle or have gotten too weak. We'll talk a little bit more about exercise later, actually. Taking the dose of steroids earlier in the day might also help with insomnia. And ultimately, reducing the steroids to the lowest dose possible is the best way to improve any of these symptoms. And we know that that's not always possible. The other big problem for people can be diabetes. So although we're doing regular blood work and monitoring this, patients may report excess thirst or urination, and if they do, they should have their glucose level checked. So if the glucose is found to be quite elevated, then insulin or oral medications may be required. And of course, this adds another level of complexity to care because there's special teaching that needs to be involved in that. Weight gain can also be an issue for people, and sometimes dietary referral can help with that. The other important thing is that when people take steroids for a prolonged time, it can result in weakened bones and the risk of breaking or fracture. So if someone is taking steroids for more than a few weeks, they should be taking regular calcium and vitamin D. And this is another case where exercise might be important to maintain bone health. And some patients may eventually be put on bisphosphonates, and sometimes family doctors get involved to help with that. Cataracts can also develop, and many patients will complain of blurry vision. There are other causes of blurry vision. So when patients develop this, it's often useful to have an assessment by an ophthalmologist to look at all the other possible causes, glaucoma and other things. Now, in some patients, Decadron can actually cause peripheral edema or swelling of the lower legs. And in many, this swelling can be quite problematic. The legs feel heavy, and in some people, they can actually seep some fluid. We can use diuretics, but they can cause dehydration. So I often recommend support stockings. Putting them on first thing in the morning is best, and starting as soon as possible before the edema becomes too significant. And finally, there is the problem of steroid withdrawal. And this is what makes it very challenging when we're trying to reduce the dose of steroids. It does not take long for a person's body to become dependent on steroids. And as we try to wean them down, patients can experience headaches and fatigue and even achy joints. So when they develop the headaches and the tiredness, the challenge when we're weaning steroids is determining, is this just a symptom of the withdrawal or is the brain edema actually getting worse? Now, in some patients, we're able to stop steroids eventually. And then we're hoping that a person's own adrenal glands will start to work. And these are the glands that make your own steroid. They may not function well after being on steroids for a while, or they can take a long time to recover. So some patients may need ongoing steroid replacement. And the care team will often check morning cortisol to see if someone's adrenal glands are working. Now, when we make changes in steroid doses, the symptoms should hopefully level out after a few days if it's just because of the steroid withdrawal. But if they don't, that's an indication to contact the care team. So just a quick word about steroid tapering. The goal is to find the lowest dose that controls the brain edema and minimize the side effects. And this is where it becomes a bit of a balancing act. So when we're tapering, how fast we can taper and whether the steroids can be weaned completely depends on how much surgical debulking has been done and how well the tumors responded to treatment and how long someone has been on it and what kind of dose they were on it. And on the other side, when people have been on it for a long time, they may just get symptoms of steroid withdrawal, or there may be some edema that develops around the tumor as we're decreasing it. So that becomes a challenge determining which one of those is going on. So as I mentioned, it's a balancing act, and there can be an up and down with this, and it can take some time. So now we're moving on to the third and final objective, and this is understand the causes of fatigue and management strategies. So cancer-related fatigue has a general term. This is a distressing and persistent, I'm going to read this slide, subjective sense of physical and emotional and or cognitive tiredness or exhaustion. And it's related to the tumor and the tumor treatment. And it's not proportional to recent activity, and it interferes with usual functioning. Now, when we consider fatigue or tiredness in patients with glioblastoma, it's often due to a combination of the treatment, the tumor, and other causes. So when I see a patient who has tiredness, I want to make sure that I've looked for all the other causes that might be contributing to the fatigue. Some of them might be modifiable. Now, I'm not going to go through this long list with you, but things we think about could be, is their thyroid working? So maybe some people need to have their thyroid checked and need to go on to replacement. Sometimes other medications can cause tiredness, and the anti-epileptics are known to do that, as that's the anti-seizure medications. And sometimes people are already taking things like antidepressants and anti-anxiety medications, which can contribute to this. As well, if someone isn't sleeping well, they're going to be tired. And even social circumstances are important to consider because the stress and worry about that causes fatigue. So once we've looked at all of the other possible causes of fatigue and modified what we can, in the end, we're left with fatigue. And that is usually the result of a combination of factors. Now, when describing fatigue, it's important that we get a sense of the severity. So in oncology, we describe the severity of symptoms, again, in terms of grade. And this allows us to communicate in a way so that we're all talking about the same thing. So when we think about fatigue, we will grade it as 1, 2, and 3. Now, grade 1 fatigue is what many people might have if you go for a walk and you feel tired, you sit down, you rest, and then you're able to continue on and do your normal activities. Grade 2 and 3 fatigue are quite significant, and it's a type of tiredness that many patients going through this treatment experience. Now, grade 2 fatigue might not sound like much. Grade 2 is kind of a low number, but in terms of what it means, it's tiredness that's not relieved by rest, and it limits what people can do in terms of their shopping or running errands. They sometimes need people to go and do those activities because they're just too tired to do that. And grade 3 fatigue is the worst type of fatigue. And again, this is fatigue that's not relieved by rest, and it limits activities just like getting washed or dressed, and people often need help with that. So I'm going to go back to the study that I showed you that was published in the New England Journal, and you can see the treatment schema on the top. And then we're just going to look at how much grade 2 and 3 fatigue did people have. So if we look at I'll pull it up here. What happens after you have the 6 weeks of radiation? Well, in those who just received radiation alone, about 26% or a quarter of people experienced significant fatigue. And when you add chemotherapy, it's around 33%. If we fast forward now to where people have completed that 6 months of treatment, so in the group of patients who only got radiation, still about 30%, but still a significant number. But those who continued on to complete the 6 months of chemotherapy, around 51% or half of patients are suffering from fatigue. So what can we do to deal with this tiredness? I kind of liked how the Cleveland Clinic had describe this. And I like to think of this as 4 main things. So I've divided things into energy conservation, nutrition, exercise, and stress management. So where do you start? Well, it's not a bad idea to keep a diary because sometimes people aren't really sure about when they're feeling tired. So if you jot down when you feel tired and when you feel most energetic, and then you can also note what are the contributing factors, and then this will help you plan your day better. The other thing I recommend is that people pay attention to the warning signs of mounting fatigue. So instead of letting oneself get exhausted and then paying the price of having to go to bed and rest for 2 days, listen to the signs that you're getting tired and then maybe take a break. So tired eyes, stiff shoulders, or you can't concentrate anymore or feeling very irritable. These are the warning signs and it can tell you, okay, I got to slow down. I also think we can describe our own energy like the battery in your iPhone. So when you use your iPhone for simple tasks like texting or just speaking to someone, this uses a lot less energy and your battery is going to last a lot longer. But if you want your iPhone to play a movie and do games and do a Zoom call, you're going to use up your battery a lot quicker and have to charge it more frequently. So I would just say, think of your energy as a battery and use your battery wisely, recognizing the more you want to make yourself do, the more you're going to have to rest and take that into account during your day. So what can you do to help with fatigue? Well, let's start with energy conservation. So just like we all schedule meals, maybe it's not a bad idea to schedule periods of rest. And as I've mentioned, recognize the warning signs and rest before you get tired. It's also important to prioritize. So now is the time that people look at what are the activities that are most important. And it doesn't hurt to delegate tasks because many times people want to help. And if you can give them tasks that they can do that you don't have to, that will conserve your energy and your battery. We can't forget nutrition. Sometimes people's taste is altered because of treatment, and they may not be taking the right number of calories in or the right proportion of protein or carbohydrates. So a dietary referral can be useful, and hydration, we can't forget about that. If you're dehydrated, you're going to feel tired. The other thing is exercise. So as I mentioned, when some people present with a brain tumor, they in retrospect indicate that they had some tiredness, and then they have surgery and they feel tired after that, and then go under radiation and feel tired. And so this results in decreased physical activity. And that leads to people feeling tired, and that leads to lack of energy. And then the vicious circle continues. And it's really hard to break. And I know it's hard to get motivated to do exercise, but we do have evidence that it can be very beneficial in many different types of tumors, including patients with brain tumors. So it can improve your energy, it improves your mood, and also cognition, and it can improve sleep and muscle strength. So there's a number of things more than this, but it turns out that this is a very valuable thing to consider. So what kind of exercise? This is going to depend on your prior level of fitness, depends on the type of deficits that someone has, and some people might need supervision by a physiotherapist. But I guess the key would be to have both aerobic exercise, so something that increases your heart rate, and also something like strength training to keep up your muscle strength. And it can be any number of activities, and I've just shown you some things on the right. It can be quite variable. So the woman on the far right has very weak legs, maybe from the steroids. So just going from sitting in a chair and using a device to help her stand up and repeating that will hopefully improve the strength in her legs. And that might also give her energy if she's moving more. Or if the other lady to the left is just using hand weights, if she's in a wheelchair and she can't do anything else, that can increase your heart rate and make you feel better and also improve your grip strength. So a number of things can be done, and some hospitals have physiotherapists who can work with them. And the final thing that we'll talk about is stress management. Many times when people are going through treatment and they finish the 6 weeks of radiation and chemo, they just think they're going to get right back to what they used to do, or even in that period going through treatment with chemotherapy on its own. But what people usually find is it's going to take a while for them to recover their energy. So it's important to adjust expectations. It's very stressful when people try to do everything they used to do. So it might be a good idea just to try to complete a few tasks each day, and then you don't feel the stress that you have to get so many things done. The other thing is support groups. Those are very important. And the Brain Tumour Foundation of Canada have been having virtual support groups. Many centers have their own virtual groups. So I think that's an important resource for people. Each center probably have their own psychosocial oncology team who can meet with people, and they can teach relaxation techniques that people can do on their own. And the other thing that's helpful for reducing stress, which then leads to fatigue, is finding activities that are going to divert your attention but not use a lot of energy. So some people like to knit, some people read, or if they have trouble with reading, they could even just listen to an audiobook or listen to music, just ways of distracting themselves. Finally, I wish I could tell you that there was a medication that could fix all these problems, but there really is no magic pill. Studies have looked at various types of medications, and some studies have been positive and some negative, but you know, these pills also have side effects of their own. And I would have to say that it would be very select people that might benefit from medications. And in the end, I think all the things I've mentioned previously are probably the most beneficial that people can do. Who needs one more medication? So I hope I'm finishing on time here. And I hope what you've seen is that a person going through treatment for a primary brain tumor has to deal with a lot of symptoms from treatment, but also other non-specific, more general symptoms, and they are all interrelated. So I hope you've become a little bit more familiar with some of the common side effects of radiation and chemo, maybe understand a bit better why we use steroids and what are their side effects and why it can be a challenge when we're tapering them. And then maybe understand a little bit about more fatigue and then what you can do to help yourself.
Great.
So,
Thank you so much, Dr. MacNeil. That was a really practical presentation with a lot of really great tips. So thank you. We did have a few questions that came through, so I'll just read some of those out to you. I will mention to everybody listening, and I should have mentioned this before Dr. MacNeil's presentation, we really try to avoid answering specific medical questions because it's hard for the physicians to kind of give a fulsome question, not knowing your history. So if I do kind of skip over a question or part of your question, that's just the reason why. And if we don't get to your question, we will follow up by email for sure. But one of the questions somebody said was after her brain tumor removal and 33 sessions of radiation, she feels that her body feels really, really heavy from the neck down. Have you heard of this before at all, Dr. MacNeil?
Well, I think that, you know, patients might have been on steroids for a while, and depends on how much of the brain has been radiated. And there's probably a lot of things to think about. I'm sure it's multifactorial. And like I say, you know, if there had been any period of steroids and then people come off of them, sometimes like joint complaints can go on for quite a while. But it might depend on how much of the brain was radiated.
Perfect, thank you. Another question is, will constipation eventually self-correct? I guess it probably depends on the person.
Yeah.
Types of medications they might be on as well.
Yeah, and you know, it's amazing, the ondansetron, I mean, it works great to prevent nausea, but it really does cause constipation, and it can be quite significant in some people. So it does go away, but it won't go away on its own. So it'll go away once you've stopped ondansetron, but some patients need to take PEG or really higher doses of Senecot, so upping those even twice a day PEG. So it can take a lot sometimes, and sometimes it's hard to play catch up. But once you stop the ondansetron, that should get better. But yeah, some people need to take a lot of other stuff.
Yeah, and I guess it's important to have that ongoing dialogue, right, with your healthcare.
Yes, absolutely, just to make sure there's nothing else going on.
Yeah, for sure.
Yeah.
Another question is there anything that can be done for swelling, for the swelling from steroids in wrists and face specifically? Or is it kind of, I think it has to do with the dose, doesn't it? And over time.
It does, yeah. And some people are more sensitive to the side effects of steroids than others. So with some people, a very small dose causes a lot of that weight gain. And so the redistribution of the fat and some fluid retention as well. The best option obviously is trying to get onto the lowest dose. Otherwise, you know, a lot of the times people have a really sweet tooth when they're on steroids, so they tend to be gravitating to the carbohydrates, which really can put on a lot of weight. So maybe looking at what the diet is, and maybe it might help. But that also causes people to retain fluid, is when they have a lot of carbohydrates as well.
Right. Okay. Thank you for answering that. Another question is actually in relation to the COVID vaccine. Is there a concern for someone taking chemo, temozolomide, and getting the vaccine at the same time? Or is that one of those things that somebody should talk to their physician about directly as well?
Yeah, I mean, I think you really need to talk to your own physician, because there may be issues specific to each person. Generally, when we look at the flu vaccine, getting the vaccine when you're on daily chemo is a bit challenging, just because you may not mount the same kind of response. You tend to like it better when they're on monthly chemotherapy, so you can give it in between. Now, they may be recommending with COVID, any degree of protection is worthwhile, but probably something that they can discuss with their treating team.
For sure. Another question is, if a patient experiences worsening dementia, agitation, exhaustion, and instability, would they need more or less dexamethasone? The person's fatigue is between a grade 3 and 4 fatigue.
Yeah, and therein lies some of the challenges with steroids. And so it's very helpful when we have imaging. Of course, we can look and see on the MRI how much swelling is there. But it also shows us the degree of what we call the scarring from radiation. So sometimes for older patients, and I didn't go through treatment of glioblastoma in the elderly, that would be a whole talk on its own, but the older someone is, the more susceptible their brain is to the side effects of radiation. And so imaging certainly can be very helpful to try to show us, is it the tumor that's getting worse? Is it just the scarring and damage from radiation, or is there more swelling there? So before we would play around with the steroids, imaging I think would be helpful. And of course, you want to make sure you've ruled out other causes. So in older folks, medications can cause problems or infections. So you kind of have to look at the whole picture.
Sure. For sure.
Yeah.
Another question is, lots of questions. We may have to slow down on the questions in a few minutes. So once again, I mean, all great questions. Thank you. If we don't get to your question, I will follow up, or maybe I can reach out to you, Dr. MacNeil, if you have a couple of answers for some of them. Another question is, I often encounter concerned family members who insist on stimulating or kind of forcing the client to stay awake, interact with visitors. They seem to think that the client, so I'm assuming this is a healthcare professional, assuming the client must maximize the remaining time by being
right.
busy,
Right.
as well as kind of pushing them to move, to walk, to remain active. Any suggestions as to how this could be addressed?
Well, I kind of went back a little bit to show the energy conservation, and this is the key, that it's a fine balance between stimulating someone to be engaged and knowing that when you're tired, sometimes you just need a little motivation and need a little bit of stimulation. But at the same time, if that tires someone out, they're going to then spend a lot of time resting. So sometimes talking to family and explaining that we really need to conserve energy here. And the person only has so much energy, and we have to divide it up. And so maybe you have to schedule things where some family members will meet one day and then the next day. So I think people need to understand that it's good to be there to support people, but there is only so much energy someone has, and you have to choose how you spend it. And I think family needs to kind of have that discussion.
Yeah, be flexible with that.
And be flexible. Yeah, it's
Yeah.
not that people don't care or want to visit. It's just when you visit with somebody, you have to have the energy to be engaged. And so if, as I say, you try to do too much with your iPhone, you're going to run out of the battery pretty quick. So you really have to try to, limit those kinds of things.
For sure. This next question, I actually might be able to answer it, but it's what effect can reflexology have? I know it is huge for stress management. I'll just say that from our perspective at Brain Tumour Foundation of Canada, any kind of complementary alternative medicines or treatments, whether it's massage, reflexology, acupuncture, or any vitamins you might be taking, anything like that, you want to speak to your healthcare team just to make sure, if it is something that you're taking orally, to make sure it's not contraindicating with any medications you're having. but also, yeah, I mean, those types of therapies can be very good for stress reduction for many, many people. I don't know if you want to add anything to that, Dr. MacNeil?
No, when it comes to those kinds of things, I rely on our psychosocial team. They have a group of people and they can advise regarding all of those. So I do kind of need other people in our team to discuss that.
That makes sense. Yeah, thank you. Somebody said that they noticed at the beginning of your presentation, there was a publication that was dated between 2002 and 2005 by a group of doctors. She's just wondering, has there been any updates since then at all?
I guess that was the one with the glioblastoma, the standard.
I believe so, yeah.
Yeah, and that was first line. So there have been a number of studies done, and I'm not sure if Denis is going to be mentioning it, but and I didn't show it because it wasn't part of systemic therapy or radiation, but there is the Optune device, and that is where people have these, not electrodes, but these patches that disrupt the tumor, and they wear these electrodes on their heads up to 20 hours a day, I think. And in that particular study, just like the one I showed you, after radiation was finished and the temozolomide, people went on to temozolomide and they used the Optune device, and that did show an improvement over just standard of care. Now, the challenge with that is the company actually needs to be involved, and so they still remain in the United States. I have questioned them many times to sort of inquire, are they coming to Canada? And so far they haven't. It's very expensive, and I suspect that's part of it. But other than that, there is a tremendous amount of research going on because these are challenging tumors. So a lot of research is going on, but it does take time to move things up to the first line and change care.
Yeah, absolutely. Thank you. Can you talk about the differences in the 70+ age group?
Right.
You were saying it could be like a whole other presentation.
It actually is, and I have a whole talk about that. So, and that's why I didn't go into it. But that study that I showed you, which is the standard for people up to the age of 70, because I was trying to make sure I didn't go over time, but that was up to the age of 70. And at that point, people were worried that if we treat older patients too aggressively, we already know that they have a difficult time with treatment and they don't do as well. So we did do a randomized study, and again, this is a positive thing between Canada and Europe, and we've done these two studies. So patients over the age of 65, instead of getting 6 weeks of radiation, they got 3 weeks of radiation combined with temozolomide, and then went on to temozolomide after. And then the control arm, people just received radiation alone, and it did show that the combination improved outcome. The challenge, though, is that older patients tolerate treatment much less, and it can be quite variable. So there's a whole way you would approach a geriatric patient in terms of determining their fitness for treatment and whether they can continue on. So we know they can benefit, but we know they also tolerate treatment, a little bit more difficult, with more difficulty.
Okay, thank you. I'm going to stop the Q&A for now. I know there'll probably be some people that are disappointed that we didn't get to your question, but I will look over your questions this week and get back to you. There are a lot of questions about steroids, so I think there would be some benefit for our programs and services team at Brain Tumour Foundation to create an information sheet. We have had presentations in the past on steroids. I'm not sure if they're up to date on our website, so I'll double check that. And we always send an email out to everybody who's registered for today's webinar to let you know when the recordings are up. So I will include some extra links and resources for everybody specifically about steroids. And if you asked a question that wasn't steroid related, I will follow up with you directly by email, and I'll touch base with you, Dr. MacNeil, if I need some clarification on something. So thank you so much for joining us today from Halifax. Really, really appreciate it. And have a great day.
Thank you.
Thank you.